Hi, everyone. My name is Dr. Hugh Nguyen, and I just have a quick lecture for you on E&M coding and clarifications associated. And so at the bottom here, you'll have a link, and this will go to the 2023 E&M guidelines from the AMA. And so the document is it's pretty long, but the first 20 to 22 pages is what you'll need to go through. The text is large, and so it shouldn't take more than 30 minutes to an hour for each run through, and I would recommend going through it 3 or 4 times to get really familiar with it. It'll probably be the best time for money that you've spent, especially once you get better and more efficient at coding and increase your efficiency. It's worth a lot to you. So the reason we want to do this is that you really can improve your RVU production quite a bit, and also just reduce the how much you have to document. So for a lot of us, we weren't trained very clearly on how to code between a level 3, level 4, level 5, etc. And so we do it based on just what we feel like it should be, or things that you think it that you were told that for instance, the patient comes in with a new problem and you write a prescription that's a level 4. Well, it's not always true, and so we want to know exactly where in the line a level 3, level 4, level 5 is. And so there's no question, and then you're not getting pushback from the insurance or billing and coding. And so these are the values currently that we have for each code. And so you can see the difference for the new patients and the existing patients, but there's a big difference between a level 3 and a level 4. And that's where most of the meat is left on the bones that we are trying to capture. There's a 71% increase in RVU from a level 3 to level 4 for new patients, and a 54.6% more for existing level 3, level 4 patient. And so if you look on this chart over here, um, this is the median for 2025 of IM and FM and some of these specialties. And so typically each RVU is worth about $50, and the median annual is about 5,800 to 6,000 or so. And so if we just assume a value of 6,000 and then 50 RVUs $50 per RVU, and you code 50/50 between 99213 and a 99214. This is just to make it simple. You're not going to be doing a lot of level 2s or level 5s. And so just by converting 10% of the level 3s to level 4s, and so then your split becomes a 45/55, you generate 148.6-ish more RVUs, and that comes out to about $7,400 extra on your bonus if you do meet a production bonus. Now, a 45/55 is a pretty low and modest improvement. And if you're somebody who is coding mostly level 3s, you could go up 20-30%, and multiply that by quite a bit. And so that's just something to consider when you're spending 3 or 4 hours reading that chart or that document that I linked above. And this is the matrix that they give you. This is the 2021, but it hasn't changed too much in 2023, and so we can still use this. They don't have as clean of a chart that I have been able to find for the 2023 version. And so, and as we may all know, to hit a moderate or high or certain level, you need to hit 2 of the 3 columns. And so, for instance, if you have high complexity, moderate amount of data, and then low risk, it's still only a moderate. And so, but we'll address each column. So just briefly, what's considered a level 2? Basically, level 2 is something very self-limited or minor, resolves little or no intervention. Somebody comes in with a mosquito bite, you tell them that's going to get better on its own, send them home. That's a level 2. If you have to rule out anything or make any medication decisions, it's not a level 2. And so we really want to zone in on the zoom in. That's what I meant, on the level 3 versus level 4. So between low and moderate. And so we'll go each section separately. And so I want to get a few definitions because, when you look at this, they say one stable chronic illness. What defines a stable and chronic? And so, stable is a problem that you expect to last at least 1 year until the patient dies. And for the purpose of defining chronicity, conditions are treated as chronic whether or not the stage or severity changes. So, uncontrolled diabetes versus controlled diabetes is still considered a single chronic condition. What's the definition of stable? For the purpose of categorizing, it is defined by the specific treatment goals for an individual patient. So, a patient who is not at his or her treatment goal is not considered stable, even if the condition has not changed and there's no short term threat to life or function. So, for example, patient with persistently poorly controlled blood pressure for whom better control is a goal is not stable, even if the pressures are not changing and the patient is asymptomatic. The risk of morbidity without treatment is still significant. And so those are things that you want to document. And so somebody uncontrolled hypertension, you can mention that the risk can uncontrolled long term could involve death, heart attack, stroke, kidney disease, etc. And so we'll go on to define the other things. So acute uncomplicated. And so this is a new short-term problem with low risk of morbidity for which treatment is considered. There's little to no risk of mortality with treatment, and full recovery without functional impairment is expected. A problem that is normally self-limited or minor but is not resolving consistent with a definite and prescribed course is an acute uncomplicated illness. So something that you are expecting to get better, but that's not getting better, and you may have to treat it with something is considered acute and complicated. And so in this section, it says one or more chronic illnesses with exacerbation, progression, or side effects of treatment. And this is what you only need one of these to qualify for the moderator level 4. And so what does this mean? It means a chronic illness that is acutely worsening, poorly controlled, or progressing with an intent to control progression and requiring additional supportive care or requiring attention to treatment for side effects. And so there's a lot in here, and this is one of the things that you'll use a lot. So exacerbation, progression, or side effect of treatment. Um, you can, for instance, you treat somebody with ibuprofen and it causes uh, reflux or GI issues. That's considered a side effect of treatment. If you have to require attention to treatment for side effects. For instance, uh, a statin that can cause muscle aches and myalgias, um, or a chronic condition that is poorly controlled, like earlier stable, when you consider unstable. And so the other thing is 2 or more stable chronic illnesses also qualify. Somebody comes in with hypertension, hyperlipidemia, both are stable, well controlled, that qualifies. And so the next one is acute illness with systemic symptoms. And so an illness that causes systemic symptoms and has a high risk of morbidity or mortality without treatment, morbidity without treatment. And so for systemic general symptoms like fever, body aches, or fatigue, and a minor illness that may be treated to alleviate symptoms, see the definition for self-limited or minor problem or acute uncomplicated illness or injury. And so they go into much more detail in that document. But generally, some people can argue that a fever at all is considered systemic. So that's kind of for judgment because fever in a cold is not necessarily considered systemic, but a fever in a UTI would be considered systemic. Um, and so, for this third one is that one undiagnosed new problem with uncertain prognosis. And so, uncertain prognosis is important because the problem is a differential that represents a condition likely to result in high risk of morbidity without treatment. And then so the AMA actually says that the final diagnosis for a condition does not in and of itself determine the complexity or the risk, as extensive evaluation may be required to reach the conclusion that the sign or symptoms do not represent a highly morbid condition. So just to focus in on this, a you have a 20-year-old otherwise healthy person that comes in for chest pain. When they walk in, you're probably thinking anxiety, costochondritis, and you don't expect anything serious. But you still consider those differential diagnoses, and you rule out, or at least give yourself enough evidence to rule out, confidently say that they don't have anything serious. So you might still do the chest X-ray or the EKG to rule out a serious condition. But when you document it, you should document your reasoning in it, that you did consider it as you did consider a heart attack as part of the differential, and that you uh, did certain diagnostic testing and imaging to give yourself a confident, um, the confidence to say that it's likely not a cardiovascular event. And so, if you didn't mention any of that, and at the end you just put down the diagnosis as costochondritis, you probably won't be able to push it into a higher level of complexity. But and so this is where it's important to document your thought process, because they do count what's considered and what's in the differential, and not the final diagnosis. And so the next one, what is considered a complicated injury? And so complicated, an injury that requires treatment that includes evaluation of body systems that are not directly part of the injured organ. So the injury is extensive, or the treatment options are multiple and or associated with risk of morbidity. So basically, if it affects another part of the body, or the treatment is associated with uh, risk of harm, or you need multiple things to treat it, it's considered complicated. So just a few documentation tips of what we discussed. Um, don't use stable when you talk about the condition in the assessment plan. Instead, you can write improving, not improving, unchanged, but not at goal. So the not at goal part is important, um, because even if something is stable but not at goal, it's not technically stable. And so, for the sake of kind of spoon feeding the documentation to billing and coding and the insurance companies, just be very explicit with everything and just say not at goal. You can also, so for the section that says that prognosis is uncertain, you can say differentials include blank 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 blank. Testing was done, which effectively eliminates this. Or you can say further testing is needed to determine etiology, and then you can even say prognosis is uncertain, so that there's no question whether your documentation qualifies this or not. And so you can also include a risk statement. So if you're trying to raise the level of complexity of the problem, and this is different from the risk statement uh, associated with treatment and testing, which we'll also talk about. And so, like I said earlier, you can say the risk statement of untreated hypertension, and and I want to clarify, you don't have to do this for everything. And so the whole purpose of this is that so you can put statements in that allow you to hit a certain diagnosis, or a certain E&M code. And then once you get there, you can kind of relax and not have to fluff it so that you can hit something. The problem is I see a lot of people who they just chart everything and write a ton of stuff under each assessment plan because they want to make sure that it is a level 4. And really, when I document, once I know I can get to level 4 or what I need to get to level 4, I can relax, put in only the stuff that I need, the lawyers need, and then other providers who are reading the note will need. But you don't have to just load up the note with a bunch of stuff just to because you're not sure what is the level 3 and level 4. And so we'll move on to the second column. This is amount and complexity of data to be reviewed and analyzed. And so you need either, so in category 1, you need 2 of the following. So review of external notes and each unique source, review of test results and each unique test, and ordering of each unique test. And then, or you can just have category 2, which is assessment requiring an independent historian. And so, and an independent historian is just anybody else that you talk um, to get history that's independent from the patient, because either the patient is not, capable of providing an accurate history, or the other person can add on to the history so you can get a better clinical picture. And then for a moderate, it's the same thing, but in the requiring independent historian is added up to category 1, so it counts as a test. Um, and so in the category 2 becomes independent interpretation of tests. And so we'll talk about each of these very specifically, what the definitions are, and then discussion of management of tests or interpretation with other qualified healthcare professional. And so what counts as a test? So ordering a test may include those considered but not selected after shared decision making, and this is important. So they talk a lot about thought process. And so if a patient requests diagnostic imaging or labs that are not says necessary, and you discuss that you told them it was necessary, you can count it as one of these criteria. So a lot of times patient will come in and say, I want testing for everything, or at least I want an x-ray for my ankle, but they don't necessarily need it and you're not really concerned, and you talk them out of it. It still counts because you use just as much thought process as you would if you were to actually order the x-ray. And so the other thing is that a test can be normally ordered or performed, but due to a certain risk, you don't do it. You just got to document these things. So what is considered a unique source or unique test? And so it's defined by CPT code. So a hemogram is considered a single test. The CBC is also a single test. Panels are considered a single test because it's all based on a CPT code. So if you order a BMP and a AST/ALT, that can possibly be considered 3 independent tests or unique tests. But if you ordered a CMP, that would just be 1. And then the other thing is that reviewing your own notes or notes from someone in the same practice does not count as unique source or test. So per AMA, tests ordered are presumed to be analyzed when the results are reported. Therefore, when they are ordered during an encounter, they are counted in that encounter. Tests that are ordered outside of an encounter may be counted in the encounter in which they are analyzed. And so this is important, because if you ordered a CBC during an encounter, it counts as one element. If you ordered it today, you get results in a few days later at home, and then you respond to it. You review it during the patient's next visit. It does not count during the second visit. However, if a CBC was called in 1 week prior to the visit, and then you interpreted it during the visit, it does count. You order a point of care A1C and you interpret it in the same visit, it still only counts as one element. And so basically you can only count it once. You can't count it twice. And so this is one I use a lot, actually. So independent historian, an individual such as a parent, guardian, surrogate, spouse, or witness who provides history in addition to the history by the patient, and who is unable to provide a complete or reliable history, either due to developmental age, dementia, psychosis, or because you just need somebody to confirm the history and you judge it to be necessary. And so you'll see basically any child that comes in with a parent, if you document that history was obtained from the parent, that's a freebie right there. And so to qualify for a level 3 low complexity, you only need one single. So that's enough to hit a level 3. And this is why it's so easy to hit level 3 and you almost never need to do level 2. And then each independent historian counts as a separate element to help fulfill the 3 in category 1. And so if there are 2 parents there and you got history from both, that counts as 2. And then you only need one other test or you review one external test, and that is enough. Let me go back for a second. And so independent interpretation of tests, and this is important, that you can't read an x-ray report, because that doesn't count. You have to interpret the x-ray yourself, and you have to document and say this x-ray was interpreted independently or reviewed and interpreted independently. And then this category 3, discussion or management of tests or interpretation or with external physician or other qualified healthcare professional or appropriate source, not separately reported. So you call up one of their other specialists and talk to them about it. It counts. It doesn't have to be a physician. It can be any uh, professional. And so it could be PTOT, speech, anything like that. So just a quick recap and some documentation tips. And so use the independent historians. In my templates that I make, I always say history obtained from, you can say patient, and then you can add whoever. Um, Always document your thought processes if you need to. Any test you considered but decided not to use, and why. And then also any tests the patient requests but are not necessary. And again, you don't have to do this for everything because you don't want to get into the habit of over um, documenting, where these are just tools that you can use to ensure that you can hit the level 4 or level 5, and you can stop having to worry about it too much. And then, like I said, document any discussions with qualified healthcare providers. And so this is the last column. And so, and this is a risk of complications and or morbidity or mortality of patient management. So complications from the condition and for treatment. For the purpose of medical decision making, the level of risk is based upon consequences of the problem addressed at the encounter when appropriately treated. So risk also includes medical decision making related to the need to initiate or forego further testing, treatment, and or hospitalization. So, for instance, a low probability of death may be high risk, whereas a high chance of a minor self-limited adverse effect of treatment may be low risk. And so um, the next thing is morbidity is a state of illness or functional impairment that is expected to be a substantial duration during which function is limited, quality of life is impaired, or there is organ damage that may not be transient despite treatment. And then, so we'll go over here. So moderate risk, this includes for testing or treatment or the condition. So prescription drug management is considered, basically automatically putting it into a moderate risk or level 4. So decision regarding minor surgery with identified patient or procedural risk, and decision regarding elective major surgery without identified patient or procedure risk. And then diagnosis or treatment significantly limited by social determinants of health. And then I think we'll go into a little further detail with this. So, is managing over-the-counter drugs considered prescription management? And so it used to be that it did not count, but then the AMA actually released a statement that said it's based on the risk of the medication. For instance, OTC ibuprofen in a patient with CKD or on anticoagulants does carry a higher risk and would count. But ibuprofen in a 18-year-old with no other medical conditions, probably not. And so then we need to define surgery, which is minor, and what is major surgery. So based on common meaning of such term by trained clinicians. And so it's also based on, major and minor surgery, and there's really no clear definition. And you could argue this, and I doubt that they would fight you on this unless it's pretty obvious, like a mole removal or something like that you don't have to go under, and it's just using local anesthetic, likely minor. So surgery level of risk, and this is based on the individual patient and procedure risk. It does not count the typical risk inherent in the procedure. And so really sick patient undergoing fairly routine, minor surgery. When I say minor, I mean like uh, anything that involves general anesthesia can be high risk. A healthy individual going in a more serious surgery can be lower risk, but you kind of have to just state it as such. And then the next thing, this is for the high level for level 5, and so drug therapy requiring intensive monitoring for toxicity. And so anything that requires intensive monitoring as it has potential to cause serious morbidity or death, and the monitoring is performed for assessment of these adverse effects and not primarily for assessment of therapeutic efficacy. And so we think of vancomycin IV for this a lot. It's actually tested for both efficacy and for safety. Um, and so another one is anytime you use Coumadin or warfarin, um, that's both for efficacy and for safety. Just mention it if you need to. So let's do some quick examples. And so I just want you to try to, in your head, think of whether this is level 3 or level 4 and why, and then what you have to document to make it such. So first example, 45-year-old male presents for a follow-up of hypertension. He states his blood pressure usually runs 150s over 90s despite taking HCTZ 25 milligrams daily and losartan 50 milligrams daily. You raise the losartan to 100 milligrams daily. And so this one's a level 4 because you need to hit two of the three. He only comes in with one chronic condition, but because his blood pressure is 150s over 90s, that's not considered stable. So when you document this in the assessment, you put down hypertension as the diagnosis, and there's a little note you can put down blood pressure 150s over 90s, not at goal, or currently exacerbated. And you made a change to the medication, so you raised losartan. That's prescription drug management. And if you go to the first slide, let me see if I can go back real quick. So basically on this one, you have one chronic condition with exacerbation, progression, or side effect of treatment or unstable. And then you did prescription drug management. And so you can talk about a lot of the other stuff, but sorry, let me go back and find where I was here. In your note, it can be really simple, and you can hit a level 4 pretty quickly with just this. Second example, a 5-year-old boy is brought in by his dad for sore throat. Dad reports patient has had symptoms for 2 days but doesn't know the full history. So he calls his ex-wife and puts her on the speakerphone. She says that she gave him Tylenol and Motrin yesterday, and the patient has no known drug allergies. You run a rapid strep test, which was positive, and then you prescribe amoxicillin. So level 3 or level 4. And again, it's a level 4. And so you prescribe medications that hits one of the three, one of the two that you're required for moderate complexity. And then you run a rapid strep, which only counts as one test. For a moderate, you need 3. And so luckily, you got history from dad, and then you also got history from mom. And this is important because you don't actually have to speak to them in person. You can call them, and it counts. And so, sometimes you have patients with dementia. They are accompanied by other people, or you're asking history, and you have to call and talk to his wife because he doesn't know what his dosage is. That counts. So just document who you got the history from. So simple, rapid strep, amoxicillin, 2 historians, boom, level 4. Okay, third example. A 43-year-old female presents with a cough, congestion, runny nose, sore throat that started yesterday. You run a COVID flu combo test and a rapid strep test. She was positive for influenza A, and you prescribe her Tamiflu and promethazine DM for cough. So in this one, you have a new self-limiting condition. You can say it's self-limiting. And you performed a COVID flu combo and a rapid strep. And then you prescribe medications. So prescribing the medication counts as prescription drug management. That gives you one of the two that you need, one of the 2 columns that you need. But you only run 2 tests because the rapid flu combo test counts as 1, and the rapid strep counts as the second one. This is technically a level 3 since you don't have the full 3. Now, if you did a COVID separately and a flu separately, that would qualify. Okay, so example 4. 65-year-old female presents with a cough, congestion, sore throat for 1 day. You run a COVID, strep, and flu. COVID was positive. You discuss potentially treating with Paxlovid, but upon chart review, you see that the patient is on Eliquis for a DVT. You tell the patient that since Paxlovid may increase the risk of bleeding when taken with Eliquis, benefit may not outweigh the risk. You decide not to prescribe Paxlovid and advise over-the-counter cold and flu medications and conservative management. So if on face value, basically a patient comes in with upper respiratory conditions, symptoms, you run 3 tests, but you don't prescribe anything. So that would be a level 3. But if you documented that you considered treatment with Paxlovid, but due to increased risk because the patient was on Eliquis and you decided not to, that counts as prescription medication management. And that's important to do, but you don't have to do it if you've already hit the level 4, and you don't need to put that in there to justify it. Like I said, it's just another tool that you can use to make sure that you hit that. And so once you do this over and over and over again, you'll develop the skill to where when you're seeing a patient, you know exactly what you need to document to get your level 4, and then you can relax. And so for instance, in this one, you got the 3 tests. It's a new condition. You don't get the um, new condition, but that doesn't count for the moderate. The 3 tests will count for one of the 2 criteria to hit level 4, and then considering a medication, you can even say that the patient is on Eliquis and that puts it at a higher risk, um, somewhere in there. And so that could also qualify it, but the minimum that you need is just to say that you considered the Paxlovid. And the shared decision was made to not use it. The shared decision was made after discussion, is a statement that I use a lot, just to make sure that you have that statement in there, and then you're basically spoon feeding it to the billing and coding and the insurance companies. So number 5, 55-year-old male presents with routine follow-up for hypertension and type 2 diabetes. Hypertension is well controlled on losartan 50 milligrams daily. Blood pressure has been consistently in the 120s over 80s. His diabetes is well controlled as well. Metformin is 1,000 milligrams BID and Januvia 100 milligrams daily. You ordered an A1C during the last visit 1 month ago, and it was 6%. You make no changes to management and don't order any new labs, and you just advise him to follow up in 6 months. But he asks you to only follow up once a year since his diabetes and hypertension has been stable and well controlled. He lives in Bing, Oklahoma, and has to get a ride to come see you because he doesn't have a car. So this one, so you have a guy with 2 stable chronic illnesses, and they're all well controlled. You do not get to count the A1C because you ordered it during the last visit. You make no changes to management, and you don't order any new labs, and so you advise follow-ups. If you read up here, only the first 4 bullets, it's probably a level 3. But down here, it tells you he doesn't have a car and he has trouble getting a ride. And so if you document this and you say patient doesn't have a car, has difficulty getting to his doctor's appointments, that is considered a social determinant of health. And so social determinants of health can be a lot of things. It could be the ability to afford medications. It could be the ability to get to appointments. It could be education level, access to healthcare is where they live. We have a lot of patients in rural areas where access to healthcare is an issue. And so if they're illiterate and they can't read or they don't have a good understanding of medications, as long as you document that social determinants of health can cause barriers to care or treatment, then that counts on the 3rd column, and so that would allow you to bump it up to level 4. But otherwise, 2 stable conditions. Let me pull back onto the 2 stable chronic illnesses over here will give you the moderate, and then diagnosis or treatment significantly limited by social determinants of health. You didn't get anything else here. So and that's the end of my lecture. Hopefully that was helpful to you. I really do strongly suggest reading this over multiple times, um, and getting a really a good understanding of it. I tried to um, dilute it as much as possible into this lecture, but there's a lot more nuance to that. And if you really want to get a good understanding, uh, you want to get to a point where you know exactly what you need to get to a level 4 in your documentation. So you're not spending a ton of time doing extra stuff. And I think it's going to be the best bang for your buck in terms of time spent, because if you're not making those bonuses, you can probably very easily get into the bonus territory. And if you are getting bonuses despite not coding efficiently, then you're going to see much, much bigger bonuses. And so go to this link. I also want to add there's a couple other codes. There's the G2211 that's for chronic care, and that's only in Medicare patients. You can throw that on there if you are if they have multiple chronic conditions and you are seeing them longitudinally. So if it's for an acute issue, you can't add it. If they come in just for a cold, even if you're seeing them, um, you know, for years and you plan on seeing them for years, it doesn't count. But if you see them for any chronic conditions and you document follow up with you somewhere in the note, and that the plan is to continue follow longitudinally, you can add that on there. And it adds like a little bit. I don't know the number for the RVUs off the top of my head, but that's something you can do too. And you can add those onto their wellness visits. And so, well, hopefully that was beneficial. If you have any questions or concerns, let me put my email in there for you. Yeah, send me an email there. All right. Have a good day.